struggling to hear at any point, folks, but thank you very much for joining us. This is Sarah Campbell. I'm Operations Director for QI and Patient Safety at the Royal College of Physicians. I'm based in our new northern offices in Liverpool, not Sheffield, as you might be able to see behind me. And it's a pleasure to be hosting you all today to talk about the new Q Exchange call on understanding alternatives to traditional outpatient appointments. And I've been reading with interest your ideas and projects as they form through the Q Exchange. With me on the line today to help me with the presentation is Matthew from the Health Foundation Q Insight and Evaluation team, who'll be looking at the recent survey in which you all participated in to give your reflections about areas for improvement in outpatients. And Dr. John Dean, who's the Clinical Director for QI and Patient Safety with me at the Royal College of Physicians, to look at re-engineering outpatients and doing redesign in a different way, and some work we've been doing down in Surrey that starts to bring that to life. So it's great to have you all here. Please use the chat box for any questions or queries you might have. We should have plenty of time at the end for Q&A, but also some reflections from Dr. Arun Lal, who's also on the line, who's been looking at your ideas and projects. And is an expert in improvement in his own right down at Basildon and Thurrock. So we will kick off, and I'm just going to try and share the presentation with you. So hopefully you'll all be able to see this. And I just wanted to start with a few reflections on the traditional model of outpatients. So what are we dealing with already, and what do we understand about outpatients in its current form? Hopefully some of you have read the RCP report on outpatients, which contained a lot of the content that I'm going to go through. But here's a process you'll all be very familiar with. It's from the referral received to outpatients to an eventual discharge somewhere down the line. And during this process, the RCP report identified an absolute multitude of functions taking place. So outpatient appointments may be giving an opinion, there to achieve a diagnosis, to review results, to allow an examination to take place, perform procedures, maybe monitor treatment responses, promote a healthier life, detect deterioration in chronic conditions, prevent admissions if at all possible, fulfill patient expectations, fulfill targets, guidelines, or commissioning requirements, safety netting, and finally providing access to ongoing care and opinion. An absolute range of purpose and function there, which I think gives some cause for reflection on, you know, if one area is changed, does it have an effect on any other of those purposes and functions, and what's the balance there? And it may be something we want to reflect on going in the Q&A later. You'll all be very aware that outpatient activity is enormous and growing. These are stats from across the UK from 2016-17, but the RCP work has identified that outpatient appointments have almost doubled in the past decade, and that's a trend that doesn't appear to be slowing anytime soon. But I think it's fair to say that it's unclear from the work of the RCP who's actually benefiting from the traditional model of outpatients. You'll see at the bottom there, if 20% of pensioners are feeling more stressed by the experience of going to an outpatient appointment, that's little evidence to show that this is a service working on behalf of patients. From the physician's point of view, the authors of our report spoke to trainees as part of the background work, and the trainees committee of the RCP didn't identify that they received any training as part of their role in outpatients. So didn't really see it as potentially a key function. And yet 85% of non-emergency activity in the hospitals is based in the outpatient setting. So how are we going to prepare the next generation for that kind of caseload, and why are we not doing it already? The traditional model our authors identified is also out of kilter with the nature of many diseases that are attempting to be treated. So exacerbations and complications do not occur in an easily predictable time frame, and instead at inconvenient and unpredictable times, which often results in attendances at urgent care, as community services are not able to respond in a way that's required to head off exacerbations, or if patients are feeling unsafe in their own homes with an acute illness. the outpatient model isn't working with the trajectory of these diseases. And despite of this, it's not for the want of policy directive or national initiatives or a case for change. These are just some of the examples of work happening around the UK, which you'll all no doubt be very familiar with. So there's a real push at the moment. Outpatients really is a hot topic across the UK. The case for change is clear. So it's really exciting to see your ideas and projects starting to form and think about how we might be tackling this issue and creating an alternative model to the traditional model that I think we're all aware isn't quite right and fit for purpose. So I will stop sharing, hopefully, if I can, and hand over to Matt to run through the findings from the Q Insight survey on improving outpatient care. Thank you, Matt.
Great, thanks very much, Sarah. I was just struggling to unmute myself there. So I'm Matt, I'm the fairly new Insight and Evaluation Manager at Q, and I want to discuss some of the headline findings from the Q Insight survey that looked at improving outpatient care. And I should say that the survey is part of a broader kind of strand of Q Insight work that we're doing within Q, which really tries to draw out the collective insight of the community, I guess, both to get that insight moving around within Q, but also to inform kind of wider policy and practice agendas. And the focus on outpatient care itself is also part of a broader kind of package of work within Q, and I think that's where Q really starts to add up to more than the sum of its parts, where we can kind of draw on different activities across the community to build a broader kind of package of work. So obviously it's a key topic for this Q Exchange. We've undertaken the Insight survey. The plan is also to run a session at the Q community event in November. So if people haven't signed up for that, they should take a look, and that session is designed to really build on all of the work that you've all been doing in terms of kind of designing and refining your ideas. And then we can plan kind of what needs to come next in terms of our work on an ongoing collaboration with the kind of country partners across the UK. Okay, so into the findings then. So I want to quite briefly present the headline findings from the survey. I should say that we will be publishing more detail on the findings in the autumn. This is really just the kind of emergent headline findings. We did have a good, pretty positive response rate from Q members. So we heard from 427 responses. That's still quite a small percentage of the community overall. So the findings aren't a kind of measure of the perceptions of the community as such. But the survey did create a really valuable space for people to contribute their kind of insights, which is what I'm going to share today. Also, everyone's from across the 4 countries. It was in Wales. We'll focus on that next time. It was about a third from primary clinical roles and 2/3 primary non-clinical. That is pretty representative of the Q community overall. And actually that diversity in terms of geography, role, organisation, I guess is a key strength of Q when it comes to kind of drawing out this collective insight. I think there's more we can do in terms of diversity, but we have got a pretty diverse membership. Interestingly, it was just over half, 52% of respondents had been improving outpatient care. And the rest, either they'd worked in outpatient but not directly in improvement, or actually they hadn't worked directly in outpatient care in any way. And again, I think in a way that is a strength because it's the perspective that people were bringing as improvers rather than necessarily direct experience that they were always drawing on. Obviously, if someone has experience of, say, digital transformation from a different service, we want to... Okay, so the first kind of headline finding, I guess, is that, the respondents really felt that improving outpatient care is an important issue. So the vast majority, 89% of respondents, saw improving outpatient care as either extremely or very important. Now, perhaps that's not surprising because they took the time to respond to the survey, but that was even in comparison to all the other challenges that are currently facing the NHS. So I think it's fair to say that people see it as important as obviously we all do. At the same time, just over half, 51%, felt that there'd been little or no progress within improving outpatient care in their area over the last decade. So in a way, that kind of high importance but little progress acts as quite a powerful call to arms in terms of the work that needs to be done to improve outpatient care. Also, interestingly, when we asked people to think about their confidence for the next 10 years, it was a bit more positive. People were a bit more confident that the scale of improvement that's needed in outpatient care will be achieved. We're not quite sure why that is. It could be that QI are an optimistic bunch, or it could be that actually because there is now that kind of vision at the kind of policy level, that there's a bit more confidence. I think, as we'll see from later slides, there's still questions around the kind of devil of the detail of implementing all of that, but there seems to be a bit more confidence. Okay, so then we asked Q members to rate their top 3 solutions that they thought offered the greatest opportunity for improvement within outpatient care. It's fair to say that there was a wide range of kind of potential solutions that people identified. And actually in the open text responses, people really stressed that, because of the scale of ambitions around improving outpatient care, clearly no one lever or no one solution is going to achieve that ambition. And actually it's multiple different levers that are going to be required, which I guess is good news for Q Exchange projects. But despite that kind of range of support for different solutions, there were clear kind of trends. So the top opportunity was improving referral and triage processes so that patients are seen by the right person at the right time and unnecessary appointments are avoided. The second one, I guess backing up some of the broader policy emphasis on the potential for virtual consultations, was that using online and mobile technology to improve patient access and reduce demand for face-to-face consultations. And the third top was improving support for self-management, which I'll talk a little bit more about on the next slide. So I think a little bit surprising for us, perhaps not for you, was the solutions that scored much lower. So actually only 2% selected improving facilities or physical infrastructure as one of their top 3 priorities, even though actually some wider work from the Health Foundation really identified kind of physical infrastructure as a key area that's required across health, not just within outpatients. And the second kind of least selected priority was making better use of the voluntary or community sector to meet the needs of patients and their families. Okay, so then we actually just asked those 52% of respondents who had undertaken work around improving outpatient care to tell us a bit more about the work that had been undertaken. And again, really the first thing to say is that a huge amount of work has been undertaken across the 427 respondents. So no surprise there, but I guess we wanted to stress that, there's that potential for the Q Exchange projects to really, I guess, stand on the shoulders of that work, not necessarily replicating it, but, really standing on the shoulders of the learning that's come out of it. Also, the areas that where people had actually undertaken work were fairly closely aligned with what they saw as the actual priorities. So again, in a way that kind of vindicates a lot of the work that's already been done. But again, as we'll get on, it's more about the detail of the approaches that may be barriers to achieving the progress that people think is needed. There were a couple of exceptions to that alignment. So there was a relatively high amount of work had been undertaken around changing the skill mix of teams. So, for example, using different combinations of clinical and non-clinical staff. But actually, that wasn't highlighted as a key kind of priority as a potential solution. And vice versa, really, for improving support for self-management. So there'd been relatively low levels of work undertaken there compared to actually people identifying it in their top 3 potential solutions. Okay, so like I say, we will actually publish a lot more of the detail from the survey in the autumn, but we wanted to draw out kind of 6 key learning points for those who are looking to support kind of successful improvement. And I think it's fair to say that these 6 will be pretty well known to this group. And actually probably the power of this perspective is most seen when we're thinking about using the findings to influence kind of broader policy and practice. And actually Jennifer Dixon, who's the chief exec of the Health Foundation, has already drawn on some of the findings from the survey to put a question to Simon Stevens specifically. However, I think the kind of 6 key points that should still be useful for Q Exchange projects, almost acting like a bit of a checklist, you know, to make sure if you've either integrated or have considered these kind of 6 things as you kind of refine your project. So the first is ensuring patient involvement, and that can range from user research to understand their experience to much more substantial kind of co-design and iterative collaboration. And actually, when we asked people to think about the things that had really held back the work that they'd undertaken, this was really one of the key things that they said, that it was the lack of patient involvement that had acted as a real barrier to the successful project. Perhaps equally important was the importance of ensuring staff buy-in. So that could be including clear communication and vision across the whole team and mobilising staff champions. And it was especially highlighted when we asked people to specifically think about the potential for increasing virtual consultations. And in the free text responses, you know, people emphasised that it was the clarity of that vision. So why was there this drive to increase the consultations? Is it about making things more efficient, or is it actually about increasing quality and flexibility for patients? The third thing, and it'd be interesting to think how this translates for the scale and scope of Q Exchange projects, is that actually a lot of people emphasise the importance of improvements looking across the kind of pathway to taking a broader system-wide perspective. Clearly, it's not just narrowly thinking about outpatient services directly. It's about how that can play out with, you know, with other services. Now, it might be that within Q Exchange there's not the scope to take that broad approach. It may not be. I guess that's a question for you all as you think about your refining your ideas. The fourth was about getting the basics right. So again, in relation to increasing virtual consultations, 64% saw that a barrier to that was that the low access to reliable new technologies. And actually in the free text responses, you know, people were mentioning things as basic as just not having a good internet connection. Well, obviously that's going to be difficult to increase virtual consultations. Or, you know, anecdotally outside of the survey, I'm sure I've heard people talk about, you know, just the length of time it takes to start up their computer. So I think it's about, you know, as often with kind of technology, again, from the free text responses, people mention it's not about whether being kind of evangelical or versus kind of technophobic or skeptical. I think generally people supported that ambition around virtual consultations, but there was a heavy dose of kind of realism in terms of what is the existing state of that digital infrastructure that we're going to, you know, these transformations going to be based on. The fifth one I think I've already mentioned, which is the importance of learning from others. You know, many people emphasise the importance of facilitating sharing across the system. Well, obviously that's what Q is all about. We've already talked about that wide range of experience and expertise which is across the community. And like I say, you know, we really want as much as possible Q Exchange projects to kind of stand on the shoulders of that work. And then finally, again, perhaps unsurprisingly from a community of improvers, really was that kind of almost call to arms for just a high quality improvement approach that creates space for testing and learning. You know, respondents really stress the importance of that time. It's not just staff time as such, it's the time for designing, testing, potentially failing and iterating kind of new ideas, as well as systematically capturing the learning from those successes and failures and moving them around the system. Okay, so they were the kind of key findings. Like I say, we'll be back in the autumn with more detailed findings from the survey, and we're hoping to combine it with a bit of other work that's going on in the foundation. But I'll hand over to John now to take on his slides.
Thanks so much, Matt. And yeah, if we hand over to John Dean, Clinical Director for QI and Patient Safety at the RCP. Thanks, John.
Okay, so hopefully you can hear me, and I hope you can see my slides. Please tell me if you can't, or if there are any issues. So welcome to those on the call. What I want to explore with you over the next 10 or 15 minutes is really to start us thinking about what we currently call outpatients as a system of systems. So I think that we have to take a very different approach when we're looking at what people need and what they're currently trying to get from outpatients. So those are the key messages that I'll be trying to highlight. Hopefully this will move down. Yeah, so I'm going to share with you work that we've been doing with the Royal Academy of Engineers and particularly Cambridge Engineering Design Centre on taking a systems approach to design and improvement, and some key elements of this. So as I say, when you apply it to outpatients, it really is a system of systems. So we have an appointment system, we have a transport system, we have the facilities of outpatients, and in fact, on the diagram that Sarah showed, which started at referral, what we actually know from the patient and family and primary care perspective is there's a whole lot that actually occurs before that. The outpatient process doesn't start at the point of referral. It starts at the point of somebody having a need that then needs to be expressed and then needs to be explored in terms of how that's met. And then we have laboratory systems and imaging systems and communication systems, etc., etc. So outpatients is a system of systems. We need to take a systems engineering approach, firstly to understand it, unpick its complexity, very much understand it from a people point of view. And what a systems engineering approach does is it starts by understanding the people involved in those systems. So that will be the patients and their families. It will be the general practitioner. It will be the professionals. It will be the booking clerks. It will be the clerical staff. It will be the cleaning staff. It will be the transport staff. These are people involved in this system of systems. And when we get to implement, after we've understood and then design something new, it's important, as we know from improvement principles, that we iterate that we test and adapt that until it works around agreed measures. And I'm going to come back to measures in a minute. So this is a diagram showing the systems engineering approach to design and improvement. And what you can see on it are a series of questions. One of the important things about this approach is that it's a coaching approach. So you'll see a series of questions which we follow iteratively to, firstly on the left-hand side, start to understand the system which we're currently calling outpatient. What are the elements? Who's involved? Who are the stakeholders? What are its boundaries? These sorts of questions. And then we need to understand the problem that we're trying to address. So what is the problem? What could we improve? How are we doing now? And again, that brings us back to measures. And then how could we improve? And what does good look like? What will be the measures of good? And then we get into developing solutions, how we measure the effectiveness of that, why we're doing the change and getting the right people together in the change team, and then implementing. And so we continue around this circle. So this is the engineering better care approach. So we've started to use this approach with Surrey Heartland's Health and Care Partnership, working very closely with Cambridge Engineering Design Centre and ourselves. And Surrey Heartlands have done work for some time on planned care and collectively have pulled together these planned care principles, which many of us would agree with and would want to apply to a redesigned outpatient system. So you can see on this many key attributes that we need to design into any solutions. But we started with the understand phase, so we started to understand this from the perspective not of the practitioners, not of an outpatients department, but actually of the patient that might have a need. And what you can see on this slide is we started to talk about Jeff, and Jeff had inflammatory bowel disease. He lived in Surrey, but he worked in London, around the country. He had a young family, and he had an exacerbation of his inflammatory bowel disease. And what he needed was not necessarily a referral from his general practitioner to an outpatient appointment and all that involved, but actually what you can see in the inner circle here is a whole series of functions that Jeff needed in order to maintain his health with inflammatory bowel disease, either when it's in control or when it has exacerbations. And then outside that, we see a whole series of things that we need to put into place if we're going to address Jeff's needs in order for him to live well and live healthily and return to health when he has an exacerbation with his inflammatory bowel disease. So what you'll see here is this is not a linear process. This is not starting from referral, going through to an outpatient appointment and follow-up. This is looking at things very differently from a needs perspective And now we start to understand Jeff's needs, then we can design a whole series of solutions to test and adapt to try and address that. So here are our main findings from the understand phase with Surrey. The first, we reiterated that outpatients has multiple purposes, as Sarah shared with you at the start of the call. But fundamentally what we found with that was that actually just talking about outpatients was limiting our thinking. We were already trying to push a patient's needs into a particular system of care, which may not be appropriate for those needs. So we need to think much more broadly. And in fact, for our next piece of work with Surrey Heartlands, we're going to stop talking about outpatients. We're going to talk about experts and people being connected to the experts they need at a time in their life with particular health or care needs. And what would that look like? So we've got multiple purposes, but once we understand those purposes and the needs, we need an infrastructure which is going to support that, be that the technical infrastructure with IT equipment, be it a booking system, be it that the patient can highlight needs and communicate with healthcare professionals, be it that they have self-care support to live their lives with their conditions. And if we're going to do this, then actually staff, be that clinical staff or support staff, need new skills, and indeed patients need new skills to self-manage, to have different types of contacts and interactions with the experts they need. What we find, even when we look in one place, is that there are a multitude of efforts going on to change the current system. And if we don't coordinate those in a planned program, and this is going to be important for the Q work, then actually one change might interact on another in a detrimental way. So we have to understand all the work that's going on in our areas and make sure that those are coordinated. And finally, and perhaps most importantly, we need a data set. We need to know what we're measuring in terms of the effect of outpatients. The current measures we have around new and follow-ups are simply activity measure. They don't say anything about purpose, anything about outcome, anything about patient experience, or anything about the system impact of these interactions. So we define quality as the triple aim of trying to balance the health and well-being of the population, the best possible care for the individual in terms of experience, safety, effectiveness, etc., but also sustainability. And that is environmental sustainability, where we feel a redesign of outpatients can have a very large impact, as you'll have seen in our outpatient report, but also financial, staff and social sustainability as well. So as we are doing work on redefining outpatients, we have to do work on measures, both the health measures, the individual health outcomes and experience, but also sustainability. And here we've given the example of environmental sustainability, which is measurable, but also financial sustainability will be important. So I hope that what I've been able to do is just start you thinking about what we currently call outpatients, what I would like to call people with health needs, meeting the experts that they require at the time they require. Thinking about that from a systems perspective, thinking about how we measure the effectiveness of it, and thinking about the individual functions that Jeff or anyone else might require and might require us to design and then improve. Thank you. So I'll hand over now back to Sarah, I think.
Yeah, thank you very much, John. That was great, and hopefully given lots of food for thought. Before we look at any questions popping up from the group, and please feel free to use the chat to pop anything in there. Could I just take a moment to go to Arun, if we can unmute you, Arun. You've spent some time looking at the projects that are coming through and had some reflection on that, but I know other sort of wider thoughts around measurement and skills, as John has alluded to. So just to give you a moment to give us your point of view.
Okay, thanks. Am I unmuted? I think I am. The technology, yeah. So I think there are a lot of very exciting projects on there. And I'm going to come back to some of the things that Matthew and both Matthew and John have said, really. And one of the things that that struck me was that we're still thinking about how to move outpatients to somewhere else, which in a way is perhaps not as radical as we might be. And John's last comment was perhaps we just need to rethink the whole purpose of outpatients and co-design around what patients really want and where they want it, rather than just thinking about moving the outpatient from the clinic in the hospital to the clinic in the GP or virtual. My general views were that I think a lot of the projects are exciting, but they don't have that clear aim, and I think that's going to be important in trying to sell it to patients and staff, and also it means it's much more difficult to think about how we're going to prove the success and choose the measures that might go with it to prove that success has happened. So I think it would be interesting for people to start thinking a little bit less about what they're trying to introduce and a little bit more about what they're trying to achieve by the introduction, and just come step back, because there may be other things that they want to think about. And the other thing which I thought struck is that there's sort of two bits to these projects, two types of projects. There's one which is set of projects which are very technological, which will obviously need one set of skills around technology and software and hardware. And then there are another set which are a little bit more social in nature, around co-design and group practice, etc. And again, they're going to have a different set of skills and education and things that are really required. And for some people, I think for many patients, outpatients is a bit of a social occasion. So many of my patients, the thing they don't like is the parking and the travel, but they do quite like the chat with the doctor or the nurse. So I think it will be important for the people doing the technological solutions to make sure that the lack of the social interaction isn't going to be a big thing. And I think that's where the patient inputs can be really important. And I think the final thing to say is measures, as John has said, really important. And of course, all the measures that we have are around traditional performance measures, and there's nothing very much around patient satisfaction, and therefore how we choose measures to prove the success of the projects. I think we have to be very imaginative. Sarah did mention about GIRFT, because I do work for GIRFT. GIRFT have been pretty quiet on outpatients. Most of the stuff is around very simple things like DNA rates and new to follow-up ratios. They are starting a pilot into outpatients, which is supposed to be in the next couple of months. So it is entirely possible that they're going to start looking at outpatients' performance and outcomes in a much more detailed way, and perhaps with some interesting metrics which may be useful to the group. But I believe that's not going to kick off for another couple of months. I have been in touch with the lead, but he hasn't come back to me yet.
Thank you, Irene. That's great food for thought. So for people still shaping up their projects before the end of the month, that focus on a clear aim, the purpose of outpatients, measures, the skill set you're going to require, and the different skills you're going to require depending on your type of project, and not forgetting the patient experience. I think they are really great reflections. We've had a couple of questions come in and some reflection as well. Anna's looking for other examples, so it's given a great example from Northumbria about changing the physical design of outpatients and how the hospital feels much calmer as a result. So looking for other examples of that from Q members on the call, if you've got any. And a question from Matt to John actually on measures. Matt, I don't know whether you want to come in and ask that direct.
Okay, great. I had a problem unmuting again. Yeah, John, it was really interesting what you were saying about the measures. I guess you were outlining it's almost like to really drive the change that we need, we've got to see the value of it so much more broadly to really, be that incentive and motive to, realize the level of change that we want. So it's just thinking through how we could develop a set of measures that both captures all of that diversity and breadth of value, but is still kind of manageable in terms of, performance and iteration and communication and all of that.
Yes, I think there are a number of things related to measures. The first is that we have to be really clear of the purpose. What is it what is the purpose of the interactions here, and then what are the measures related to that. We're looking at it from in my view, from the wrong lens at the moment. Our current measures are, frankly, policy measures, i.e. numbers of face-to-face contacts. Actually, we're rubbish at even measuring that in the first place. And the purpose of outpatients is not numbers of face-to-face contacts. The purpose of outpatients is the health of the people that we're interacting with in that way. Of course, as we've already said, outpatients brings together lots of different functions, lots of different people with different needs. So I think there will be some generic measures around things like patient experience, things like travel time or interruptions to people's lives, as Sarah touched on as well. But then some of the and staff experience as well, the quality of the interactions. So there are well validated measures around people being involved in decisions, about being listened to, etc., in very well validated surveys. So good patient experience and interaction data is available. Then clearly at an outcome level, we need to look, I think, at a subgroup. We need to think particularly at a specialty and a subspecialty level. There will be some clinical areas where those measures are well developed. They might actually be captured in another part of the system. So part of my my clinical practice is in diabetes. So I may see a patient with type 2 diabetes in the service that I'm part of, but actually the outcome data is with the eye service, or is with the foot service, or is in the GP practice. So think about where you're capturing the measures as well as what those measures are. There are large amounts of measures available for different disease areas and clinical areas. So in summary, what are the generic measures around access, experience, human interactions? What are the measures around sustainability, transport, cost, patients' lives being interfered with, and then what are the outcome measures related to the particular clinical focus of the interaction that you're doing? I think the other thing to say in terms of the QBID is that I would love to see one which was just about developing measures for what we currently call outpatients. And if that was the outcome of one of the bids, that could then be used in other projects, and that was co-designed with patients, staff and support staff, clinical and support staff, and maybe policy members, then that would be of great value. Back to you.
Anna, I wonder if you want to come in and just your reflections on the projects that could be joining up, or your thoughts around making the outpatient environment better than current, and the effect that can have in terms of improvement of patient experience.
Thanks, Sarah. I guess what struck me when I was looking at the Q exchange ideas, like Irene had done, is that there was a lot of potential for people to get together and work together collaboratively. So, for instance, there were quite a few respiratory ideas. As Irene mentioned, there were quite a lot of focus on co-production and how to get the patient's point of view involved. And so I guess that just made me start to think, you know, how could some of these ideas that are distributed geographically, that have kind of some core kind of values in common, maybe join up a bit and think about how they could have a bigger impact through doing that together rather than separately. So that was just my comment, really, and I'd be just really interested to see whether anyone else has noticed that, or whether anyone's got any ideas about how you might join those together, or what the panel think about that even as a concept. Would be quite helpful to hear about.
Lovely, thank you. Do we have any participants on the line, maybe from one of the respiratory projects, or people who've noticed somebody coming to the exchange with a very similar idea, wanting to make links, or any reflections at all? If you don't need to use the group chat, please feel free just to unmute and pitch in.
Hi, it's Jane from Hull. My idea was to create a tool that can be adapted to support any other specialty for a one-stop clinic, because this is an area that we're actually looking at in urology at the moment. There's also somebody that has been matched with me with a similar idea, and we converse over email with regards what they're doing and what we're doing. There's maybe another way where you could do a joint email if there's more than 2 areas, or even maybe like a WhatsApp group. But it's working for me anyway via email.
That's fantastic, thank you. Yeah, I think the Health Foundation will concur. This is where the richness really starts in the project, and we can do that sharing. Anybody else with any ideas that are coming to fruition, or links you want to make, questions you want to ask? We've got another one on the chat asking whether anyone thinks the continued use of the term outpatients is an issue. They're reminded of the change of the term casualty to A&E or ED. And it seems to help the mid-shift what the purpose of ED is. So lots of conversations today really what we're trying to achieve, which I think is to ensure a continuum of care for those who need it.
Aye.
And the term outpatients is really just based on the traditional physical space and perhaps constrains our thinking. John, I think from what you were saying about Surrey, that's probably pretty much on the money.
Yeah, that was a very, very strong message from participants and particularly from patients, you know, in terms of what they needed was an interaction with experts, not to come to a physical department, or if it doesn't matter where and how they connect, what matters was that they connected to meet that need. So I feel very strongly that it is constraining our thinking, but I'll be very interested in other people's thoughts on the call.
Yeah, likewise, if anybody wants to come in. I don't know whether we've got any patient participants on the line today and their feelings about the sort of the branding about patients, if you like, or the naming.
So Anne, I think, can you hear me?
Yes.
Sorry, good. I got a message to say my internet connection was unstable. I think it was talking about the internet connection and not me. I was just reflecting on what you've been saying and the comment about changing the name, and I do think there's a lot in that. And I think John's points around rethinking the entire purpose of what we're trying to do is a good one. One of the things which I think may be useful is to do some proper, what I think was probably termed value stream mapping, and work out what's happening and what steps in our current way of looking after people actually add value either to the patient or to the care of their disease, and whether or not they could be done in a different way or in somewhere else. And to do that with patients, because obviously there will be different perspectives about what they think is valuable. But I think that may be a very good way of working out what we're doing in hospitals which could be done elsewhere, and what we're doing which doesn't need to be done at all. And I think rethinking things along a process, the whole process, is probably going to be a much more powerful way of looking about redesign.
Yeah, I think that's really important, Arun, and of course, if we do value stream mapping well, the thing we're aiming to get to is the value. So we are defining the value and then seeing what achieves that. And I completely agree.
Larry, is that you trying to come in with a question?
No, I'm not actually, sorry. Are you hearing me?
No problem. An additional one from Anna about coaching teams using new technologies to reduce the need to travel, and finding out some NHS staff are worried about new ways of working. Does anybody on the panel have ideas about bringing people along and engaging people? I'm guessing that's from the staff side, if that's the staff anxieties, and probably the patients as well with regards to technology. Matt, I don't know if anything came through in the survey about that, or John and Arun, if you've got ideas.
I'll just make a couple of comments related to that. I think that, I mean, I've done, personally done a certain amount of telephone and video consultation, as well as obviously face-to-face consultation with patients. It is a different skill, and also patients and families, you know, some will be very comfortable with those sorts of interactions and others won't. I think we also need to think around the other sectors where this is already happening and it's happening very effectively. And if you look in healthcare, there's much more experience in primary care and community care around telephone and video consultation than there is in specialty care. If we look in other sectors of service industries, social care in particular, you know, in some innovative areas, and potentially in some remote areas where there are other ways of contact. So I absolutely think there's a new, as Arun said, both a technical skill set, but also a clinical skill set here where there are experts, and we need to learn with experts. And again, you know, if one of the Q projects was trying to define those technical and clinical skills and how we might share and develop those, I think that will be really valuable.
That's great. And we have a response here about the use of simulation labs to help staff practice in a sort of quasi-real environment, I guess, to demonstrate the different skills it requires them to hone those skills as well, which is a really exciting idea, and good to know where the facilities are for that and who's using that, because that's a great example. Have we any further questions from anybody on the line? Please feel free to unmute or pop something in the chat box if you'd like to contribute.
Sorry, Sarah, I thought I'd just chip in a few other findings from the survey, I think related to what John was saying. On that particular point around kind of staff buy-in in terms of increase in virtual consultation. So like I said in the presentation, that really came out as one of the key barriers around increasing virtual consultations. It was the kind of staff buy-in and acceptance. So I guess the survey respondents really stressed the importance of that kind of overall vision and purpose for increasing kind of virtual consultations. It was lower in terms of anxieties around staff skills. One other thing that did come up was, I guess, kind of fears and anxieties around the implications for data protection and things related to that, which again, yeah, I think people stress might be a cause of kind of anxiety or confusion for some staff that it might be seen as a kind of barrier. Well, obviously it would be one that would be, you know, relatively easy to kind of overcome, but it might be kind of stifling some of the progress around that.
Great, thank you. Thanks to Stephen about the collaboration that's forming across Sheffield and Torbay and South Devon on your similar projects. That's really great to hear. And Rachel, I don't know whether you want to come on, but just reflecting that it's important to help staff see that they are still experts in delivering expert care. And if that's undermined or replaced or diminished by other methods, that could be really quite detrimental. So they're quite keen to be engaged through the process. I don't know whether you want to expand on that, Rachel. Maybe not able to join us. That's great. Thank you, everyone, for your participation. We've got a few days left, or I think 12 days left now until the end of the until the projects need to be fully submitted. So we do interject if I've got any of that wrong. We're really looking forward to the assessment process and going through these in detail. There's some really great ideas emerging, and thank you all for your time and energy going into these. It's really exciting. We'll take your comments and reflections from the chat as well and make sure we feed that into the wider group and the exchange. And please keep in touch. If you've got any questions, we'll share our RCP contact details, or you can go through the Health Foundation, and we're on the exchange group as well if you want to keep in touch. So thank you everyone, it's been a pleasure, and enjoy the rest of your day.